afternoon. We are doing a presentation on hospice geriatric with patients who have lung cancer.
This is presented by Audre Bautista
And Lyndsy Serdynski.
So lung cancer is a form of cancer that originates in the lungs and can create a lot of respiratory abnormalities. Lung cancer is the #1 cause of cancer-related deaths in the U.S. today. So when a cancer patient or their family decides to go the route of hospice or palliative care, they generally forego treatments, and the emphasis is usually on improving quality of life and comfort. So depending on the choices of the patient and the family, as far as which hospice facility to go to, hospice generally provides services on psychological, social, and spiritual needs.
There are some ACCP evidence-based practice guidelines on patients with lung cancer, and the first one is to reassure the families and patient that their pain can be managed effectively and safely. The second one is that it's important to administer the medications on a regular schedule and to treat the pain appropriately. The third one says for mild to moderate pain, it's best to start off with the NSAID or acetaminophen, and if the pain gets worse, then we can move on to the opioids.
For any patient, if it is anticipated that there will be a continuous need for opioid medicinal use, meperidine is the primary choice. Non-meperidine can actually be toxic to the patient. For patients whose pain is not controlled by analgesic medication, adjunctive medications such as tricyclic antidepressants are also useful. And for patients, for all patients, we administer medications by mouth. IV is also used in the hospice environment and the rectal route.
For all patients receiving opioids, constipation is a side effect. So it's important to treat it prophylactically and to constantly monitor that. To prevent any complications, it's important to remain active and to avoid prolonged immobilization. And for patients who have pain associated with muscle tension and muscle spasms, it can be treated with heat and cold applications, acupuncture, psychosocial methods of care, and pastoral care.
For patients with advanced lung cancer, palliative radiation therapy is also a use for pain relief. And in patients with lung cancer who have pain that is unresponsive to standardized medications, referral to a specialized pain clinic or physician is also recommended. So meet Mrs. Birch. Mrs. Birch is a 65-year-old married woman who was recently diagnosed with lung cancer. Her past medical history is limited because she does not regularly see a primary care physician. The past medical history that we have is AFib, hypertension, Alzheimer's disease, TIA 2 years ago, and she was a smoker for 20 years. Mrs. Birch was brought into the hospital by her husband after she experienced some severe shortness of breath, got dizzy, and fell down at home. She was transferred to the ICU for closer monitoring. So her O2 saturation on admission was 98% on 2 liters nasal cannula. Her GCS was 14 out of 15. She follows commands, has spontaneous eye opening, and can respond verbally. The chest x-ray showed a left lung mass and a right lung malignant pleural effusion. The CT was unremarkable, and the labs were within normal range. The patient did fail the bedside swallow study, so she is to remain NPO. And her blood pressure was 160/89 with a heart rate at 110 in AFib.
With this assessment, assessment, she was complaining of left-sided pain on her hip, and we administered 0.5 milligrams of morphine IV to take care of that pain from the fall. And when we asked Ms. Birch about her dying wishes, she nodded her head yes about wanting to go on with the palliative care. And legal documents were obtained and copied. And Ms. Birch wants her daughter to be responsible for the end-of-life decision-making. At home, she's taking carvedilol, lisinopril, Lipitor, Plavix, Aricept, and a home multivitamin.
So admission orders are continuous telemetry to monitor her cardiac function, oxygen as needed, 2 liters nasal cannula, chest x-ray, CT of the head, which were already obtained and read, NPO status until further evaluation by the nurse or speech therapy, DVT prophylaxis such as an STD protocol, vital signs every hour and neurological exams every 2 hours, and chemistries, routine cardiac functions, and a basic metabolic panel.
The scenario takes place at stage 1, and this is Ms. Birch at her baseline. At 8 a.m., she is 99% on the 2 liters nasal cannula, normal heart sounds, no peripheral edema, and there's no complaints of pain. So the interventions are to assess and identify the abnormalities, maintain the vitals between normal limits, and to obtain the O2 saturation and weights.
So why is it necessary to weigh the patient, and why is it important to check for peripheral edema?
Well, a weight is a good measurement of how much fluid is in the body when comparing daily intake and output. And peripheral edema is also a good indicator of how much excess fluid is in the body and where it is localizing to.
So oxygen is in stage 2 at 80% on 2 liters nasal cannula. She has desaturated, shortness of breath at rest, 10 out of 10 pain during inspiration, heart rate is 120, and she also has an elevated blood pressure of 170/90. She has an increase in fatigue and weakness. So the interventions are for the nurse to palpate the trachea, to look for deviation, also take the lungs, and notify the MD for a chest x-ray.
So the questions we can ask here are, what does pain during inspiration signify? And why should the nurse palpate the trachea for deviation?
Well, pain during inspiration is generally signifies pleural effusion in a lung cancer patient. Can also indicate that there's a mass or a tumor, something pressing on the lungs, or a malignant cardiac issue. And a tracheal shift is an indicator of an upper mediastinal shift, which can be life-threatening.
At stage 3 is the intervention. The MD performed a thoracentesis, and the patient ended with no complaints of pain, but does get shortness of breath upon exertion. The patient also cannot perform her ADLs without assistance, and her oxygen saturation level is 93% on the 2 liters nasal cannula. The doctor also informed the family that the prognosis is poor. The interventions here would be to provide the patient and family with literature, education, and therapeutic communication of end-of-life care, and to help the patient with energy conservation and caloric intake.
So the questions asked here are, how would you know if a thoracentesis is effective? And why is energy conservation an important factor, as well as caloric intake?
Well, a thoracentesis is generally thought to be effective when the patient no longer experiences shortness of breath or pleural pain. And caloric intake is important because the patient needs to be provided with adequate nutrition. And malnutrition is a common problem in all cancer patients and can be associated with a higher mortality and morbidity rate.
Dr. Campbell from the palliative team came by to introduce himself and discuss with the family and Ms. Birch what her dying wishes were. So they generally, when the palliative physician comes by, they define a quality of life. What would Ms. Birch consider to be quality of life? So Mrs. Birch is a religious Catholic woman who the family states has no fear of dying or death. She would not want to be on a mechanical ventilator for a long period of time, but is agreeable to the use of it in an emergent situation. Her daughter does not think that Mrs. Birch would like hospice and does not like hospitals.
Ms. Birch previously decided to forego radiation and chemotherapy due to the ill side effects, and she states her desire to live with her family as comfortably as possible. Her daughter states that Mrs. Birch does not want manual compressions or to live on a machine. She also doesn't want unnatural medicines keeping her heart pumping. And hospice and palliative care are consulted, and the patient becomes a limited code with meds and fluids and ventilation in emergency circumstances. Her daughter also states that Mrs. Birch has not been eating well lately and has lost a significant amount of weight, and with an increase in confusion. So registered dietary has been consulted also.
So in this instance, the family seems to be a little unrealistic about what hospice care provides. So this is when the physician can speak to the family, and the nurse would consult hospice or palliative care anyway, just to give them a general idea of what hospice does and what services that they can provide for the patient and the family. The registered dietitian can do a number of things, such as inserting a PEG tube for comfort feeds, or an NG tube, or anything of that nature. We can also thicken fluids so that the patient can eat, and actually provide therapy to strengthen her swallowing muscles if eating is an important factor in Mrs. Birch's life. So hospice and palliative care are generally involved when a decision has been made to regarding the treatment as an end of care. The hospice nurse explained that Mrs. Birch could be taken to an inpatient facility where she won't be in a hospital, but in a nice, close to home facility for the family.
Do not count the days, but make the days count.
This completes our presentation. Thank you so much for watching.
Thank you.